Hi, Siddharth. Welcome to VMR. Nice to see you.
Hello. Hello, everyone. So sorry. I think I just clicked the another link. So sorry for the delay.
No problem at all. No problem at all. CP Solver style, we always start a few minutes late. So actually, you were just on time. It was kind of incredible. Do you mind telling us a little bit about yourself?
Yeah. So hi, everybody. So my name is Siddharth Mahajan, and I'm a recent graduate from Government Medical College, Amritsar, India. And
Yeah.
I have also recently applied for the internal medicine match 2024. And I'm currently working as a junior resident in Amritsar itself. It's in the northern part of India. And I would like to thank everybody at the CPS Solvers for letting me this opportunity to present the case. And yeah, looking forward to meet everyone.
Wow, we are so excited to have you. And thank you for your kind words. I know Amanda, you worked directly with our case review committee leader. And I'm delighted to see Amanda here. I'm really glad you got to connect with her. How did you decide to apply for the match? I know it's a big leap to cross two continents to come here. What was your inspiration to do so?
Yeah, so actually, I have a little bit history in my family. So my
Mm,
mother is a cancer patient, and even in her siblings, they had cancer, and unfortunately, they are not anymore with us.
mm,
So seeing all the things like during their journey, I was inspired, like how most of the drugs that she was having were from the US itself.
mm.
So I got that inspiration that most of the drugs were coming from US and how the research was happening over there. So that made me motivated to pursue my career.
Incredible. I'm so sorry that it's in the face of such pain and tragedy, but it's so cool to see many people all across the world using that as inspiration to follow their career path. It's really cool. What do you like to do outside of medicine, Sudhar?
So outside of medicine, I really enjoy working out, and also I have been running. So I've been taking part in
Ah,
marathons recently.
no
Also,
way.
yeah. So also I'm kind of a home baker. So I like baking chocolate chip cookies. That is really my favorite.
Oh,
And then that I'm also a kind of writer and a mobile photographer.
oh my gosh. By the way, Sudhar, I can tell you're going to ace your interview. I hope you have many that come your way. And when you do get them, you're going to do very well. I'm not
Uh,
trying to interview here. I'm just very curious. And I think um, your the depth of your persona shines. We're very thrilled to have you here. And I can already imagine the epic combo of going for a run and then having some chocolate chip cookies afterward. That sounds absolutely delightful.
yeah,
Well,
I'll be on.
say that again, sorry.
Yeah, I'll be grateful if I could have you taste the cookies itself. Yeah.
Oh, 100%. This is the best we can do virtually though, is because I feel like hearing from Amanda, your case might be even more intriguing and inspiring than some chocolate chip cookies. So take it away, my friend. We're ready whenever you are.
Yeah. Okay. Let me just share my screen real quick.
Oh, sorry, I forgot to. Oh, let me ask you one thing. Sorry for that. Do you have slides, or tell me more about your plans to share the screen?
So I do have the slides, but I'm not sure, like, should
Yeah,
I
you don't
or
need to. You don't need to present with the slides, honestly, because we have a templated whiteboard, so you can just present from your heart and your
okay.
soul. Unless there are specific images you want to show, but the text part, you can just narrate them.
No, no, no.
Okay?
Okay, okay. So, okay, yeah, that sounds good. So I'll just narrate this. Yeah.
Yeah, and just let me know anytime you have any pictures or anything that you want to transmit to our eyes.
Okay, yeah, yeah, yeah. But
All
yeah,
right, take it away.
so thank you everybody for giving me this opportunity. So let's start with the case. So this is a 52-year-old male who is an Indian and who comes to the emergency department complaining with respiratory distress over the past 2 days, productive cough with increasing sputum production with purulence, fatigue, and fever. So these were the chief complaints that the patient presented to us.
Yeah, I think Shraddha, this is not an uncommon scenario where you have a patient who is having inflammatory features involving the chest.
Yeah,
And I think it's
yeah,
amazing how, just to reflect with everybody, um, it's amazing how the presence of inflammation really helps you prioritize where the problem is in the chest. We
Yeah.
know he's inflamed, and he's telling us that his symptoms are in the chest. And the part of the chest that's most exposed to the world, the lungs, are the most common source of inflammatory chest disease. So this immediately,
Mhm.
the localization based on base rate prioritizes a pulmonary disease process. Um, and
Yeah.
if you were to be honest, though, anything in the thorax can get inflamed. You can have pleuritis, pericarditis, endocarditis, myocarditis, anything you can put an itis next to it. But the most common scenarios are that the lungs are the source of inflammation. So the next stages of this person's evaluation is to really try to study the landscape of to try to reinforce or falsify the idea that his lungs are the source of inflammation. It is interesting to latch onto two things when you're heading towards pulmonary inflammation. And the big thing you want to pay attention to is the time course, because that is another way to stay anchored in the common things. The most common is community-acquired pneumonia, which has a time course on the order of days. So anytime that the time course is different than that, you have to pay very, very close attention to something sneaking up on you. And the other big caveat, in addition to the time course, is paying attention to the why. Almost from the beginning, you really have to ask yourself, why is this patient taking me down the path of pneumonia evaluation? And most commonly, it's because the patient has age-related immunosuppression. That's the most common, or they have structural lung disease. But here, as a 52-year-old man, we might end up with a non-specific or non-concrete answer as to why this person has inflammatory disease of the chest. But it's really immediately important to think about vulnerabilities that this person might have. So to summarize, this aliquot 1 triggers a reflex. It triggers a reflex to say this person is likely going to have inflammation in the lungs, and that's driven by the base rate. The big caution you want to do is time course. If the time course is anything but acute, you have to worry. And the other question you have to answer is, why is this happening? In older adults, a concrete specific answer may not be found, but in somebody who's 52, you certainly have to ask the question. All right, why don't you tell us a little bit more, Sridhar, please?
Yeah. So moving to the history of present illness. So the patient has a history of COPD and significant smoking history. He reported compliance with the prescribed medications, including his bronchodilators and inhaled steroids. There were no recent changes in the medications or any exacerbating factors, but he did reported occasional exposure to the dust as well as chemicals when during the history taking.
Interesting. This is definitely something worth reflecting on, in large part because we're getting signals of possibly underlying vulnerability. So remember, we have three threads to explore. Where is the inflammation? What is the time course? And what is there, if any, underlying vulnerability? And this entire segment that Srilas just presented to us makes us query about the vulnerability aspect. Does he have structural lung disease? And in fact, we hear that he has COPD. And we hear that he is on treatment for COPD and that he has exposures. I think it's interesting to reflect on the potential vacuum here. And the vacuum here is that we have a diagnosis of COPD without, at least what we've heard, a prominent smoking history. So that would ask me to, that would usually would prompt me to clarify and ask more specifically. So, Siddharth, do we know whether or not he's had extensive tobacco exposure?
Yeah, that's the next part. So under his social history, he has a 20-pack year of smoking history, but he quit smoking 2 years ago because he was started on his medications.
I
But
see.
other than that, yeah,
Interesting. Interesting. Yeah, I think 20 pack years is certainly sufficient as an explanation for COPD, though his age of onset is intriguing and may make you wonder whether he has a, a propensity to get COPD in addition to his smoking history. So, any thoughts from the group, from the chat, about other contributors or other causes of COPD that the smoking may have exacerbated? What do you all think as potential contributors to a COPD diagnosis in general? Excellent. So Mario is saying alpha-1 antitrypsin deficiency, which in and of itself can cause COPD. And in fact, in the US, there's a recommendation to check alpha-1 antitrypsin levels in everybody who's diagnosed with COPD. And Maria coming in strong with another really important global cause of COPD, which is biomass and biofuel exposure. Excellent. Any other thoughts? There's one other big one that's actually simple, which is that the patient doesn't smoke themselves, but they actually have an extensive smoking exposure to them. So secondhand smoke is often underappreciated. There are a variety of pneumoconioses too that can result in an emphysematous phenotype, and some rare autoimmune diseases that can also result in an emphysematous phenotype. But practically speaking, I think the two big things to ask in this patient is to wonder if there's also secondhand smoke exposure, and to wonder if there is other dust or environmental exposure, such as biofuels or whatnot. But practically speaking, where are we now? We are probably confident that this person's lungs are not healthy to begin with. And so the question is this person experiencing an exacerbation of an underlying lung process, usually by infection? Or are we dealing with a progression of an underlying disease that is not fully characterized and understood? And the only reason that the latter hypothesis deserves any merit up front is because the story for a diagnosis of COPD in a 52-year-old is not rock solid. If you change this and say 72 or 82-year-old, then it's a much less fruitful exercise to question the underlying diagnosis of COPD. But simply because of his age, I think you have to wonder, is he suffering an acute on chronic issue, an infection on top of structural lung disease, or is he suffering a subacute progressive phenomenon from his underlying disease? All right, just tell us more, please.
So moving to the next part, the past medical history. So as we know that is a known case of COPD, but other than that, he is also a case of controlled hypertension as well as hyperlipidemia. The medications that this person was taking was albuterol, fluticasone, and lisinopril for his hypertension, and atorvastatin for his dyslipidemia. Under the topic of his family history, so his family history was only one significant thing, that his father died from some liver disease, but he wasn't sure what exactly that was. So, and for the social history, he has a 20-pack year of smoking history and he quit 2 years ago. Other than that, he has no alcohol use or any drug use history. For his occupation history, he's a construction worker, and he said that he's exposed to some kind of dust and chemicals, like as a routine for him. He also has no reported allergies as of that particular day.
Yeah, very interesting, Sridath. You're continuing to tell us how vulnerable his lungs are and all these exposures that he has, which I'm really keep tracking of. Anytime that you have a family history, especially something that's vague as an unknown liver disease, I think it's really hard to know what to make progress with it. But one piece of advice that can help us a lot is to understand the age at which the parents passed away from said disease. So if his father died at age 32 from an unknown liver disease, it could certainly be that that liver disease was hepatitis B related, um, and therefore maybe less directly linked to this patient. But if he died at 80 from a liver disease, the connection between that and this patient is weakened. So it's not uncommon that we struggle with a lack of clarity around what the family history is in terms of specifics, and are given syndromic labels by patients who, of course, how could they know more? So one way to stratify how much connection you can make is to start to wonder at what age the patient's family member passed away. So do you happen to know, Siddharth, when his father passed away, or is that information not available to you?
Yeah, I'm sorry for missing that. So his father passed away at the age of 49, and
49.
but he, yeah. And in the chat, I saw like someone was asking about history of previous hospitalization. So yes, he had two history of prior hospitalizations for his COPD exacerbation.
I see. Yeah, I think if we anchor ourselves in the task of the people taking care of this patient, we still have to understand where this inflammation is currently, although the momentum is towards the lungs now for two reasons. The first is it's the most common in general, and it's even more likely in somebody with such a profound history of lung disease by virtue of his own history and by virtue of his exposures. The only reason the history is, in my mind, in pencil and not in pen is because of his age. Um, And then, so that's the where is the problem? Does he have any underlying vulnerability? I think the answer is absolutely yes. What is the time course? I think is now even more intriguing because we could assume this is acute, but I think the history of him having exacerbations before again keeps it open that it's subacute progressive. I think the most important thing now is as you're gaining so much momentum to want to understand what's happening right here in the chest, you cannot lose any signals of extrapulmonary disease. So in these instances, it becomes very, very tempting to try to represent this problem as an isolated thoracic syndrome, or even more narrowly, as an isolated pulmonary syndrome, making it harder to spot any extrathoracic or even extrapulmonary clues. His father's dying at 50 makes us at least being open to studying our patients' liver parameters with more scrutiny. But that should extend to any other clue you get on exam or any other clue you get on laboratory data. So keep your eyes squarely on the chest, namely the lungs, but don't put blinders on because the key clue to solving this case may be in the extrapulmonary or extrathoracic signature. All right, Siddharth, please tell us more.
Yeah. Coming to his physical examination, so for the vitals, his temperature was 101.5 Fahrenheit. So he was febrile. His heart rate was 110 beats per minute. It was regular in nature, and the pulse was palpable, not feeble. His blood pressure was 140 by 80s, and he was tachypneic at the rate of 28 breaths per minute. For his examination, his general condition, he was looking distressed. His ear, nose, throat examination was normal. On his cardiovascular examination, there were normal heart sounds, but the patient was tachy at the rate of 110. For his palm examinations, the patient was tachypneic with accessory muscle use. His chest was hyperinflated and there were bilateral reduced breath sounds, as well as wheezing was appreciated. For his abdominal and neuro examination, it was unremarkable. And for his extremities and skin, there were mild peripheral cyanosis.
Siddharth, can I just ask you one unrelated question to the case? How does it feel to be presenting it so far?
Sorry?
How does it feel to be presenting it so far? What are your thoughts on the presentation?
So I think it's my first time over here, but I think I really am feeling comfortable. Like initially I was thinking like it might be I would be nervous or something like that. Yeah, it's really comfortable. So I think I'm currently at my ease and
Good.
I'm really comfortable with that. Yeah.
I asked right now because I noticed a marked discrepancy between you and your patient. I think a lot of people when they're presenting for the first time have vital signs very similar to your patient who are tachypneic and tachycardic and flustered, but you seem to be very calm and collected with a heart rate of 60 and a normal respiratory rate, which is really, really nice to see. I think it engenders and shows the confidence that you have in your abilities for sure. I'm glad you feel that the environment is welcoming. We certainly try to do that, but sometimes even the most welcoming spaces can be perceived as intimidating. So I think it's both this space, but also clearly your comfort level with presenting in general. Yeah, I mean, I just want to reflect with you all. I work in an emergency department where we diagnose community-acquired pneumonia all the time. And it's so rare for me to see a patient febrile from pneumonia. I know that is the classic presentation of what we're talking in the textbooks, that the patient has a fever, cough, chest X-ray, infiltrate. But I'll tell you, the fever has me really, really intrigued here because I think unless it turns out that this patient has a viral infection from COVID or influenza, when patients, the more compromised their lungs are, in my experience, and I don't have any evidence that I've read to support this, I very rarely have seen regular old community-acquired pneumonia cause a fever of rounded up to almost 102. And so that really grabs my attention in real life. Whether or not it's actually applicable to the broader audience, I don't know. And I just had a patient yesterday who had a fever of 102 and had some thoracic symptoms, and he turned out to have an empyema, not a regular old pneumonia. So I think the reason this patient might be mounting an overt fever is maybe because he's younger than most of the patients I take care of. But I want to make note of that, especially for those who have similar practices I do, take care of older adults in the United States, to ask yourselves, how many times have you diagnosed a pneumonia with a fever? And I bet it's really the minority of people who actually mount a febrile response. We usually diagnose it because of a white count or an infiltrate for no other reason. So I think it really does stand out. But I think the initial management of this patient now is, well, he's in pretty tachypnic, and understanding the reason for his tachypnea is going to be really important. And the first question in my mind is he tachypnic because he's hypoxemic, or is he tachypnic because he's acidotic? And that has profound impacts for the immediate management of this patient. So I think you said it already, Sudas, but do you mind telling us what his oxygen saturation was?
Sorry.
Oh, do you mind telling us again what his oxygen saturation was? What was his O2 sat?
Hello. Yeah, so for this particular patient, when he was admitted, then he was also placed on ventilator. And before ventilator, he had a saturation of 82% on room air.
Amazing. So he was really sick and got pretty quickly intubated. And I think that makes a lot of sense because I think you have plenty of evidence for mixed hypoxemic and hypercarbic respiratory failure. When somebody's setting 82% on room air, you know that there's a component of hypoxemic respiratory failure. But remember, this is a patient with COPD, presumably has a disease of his airways, and is presenting with reduced breath sounds and wheezing. So not only are you getting a component of oxygen, impaired oxygenation, you're also getting a component of likely impaired ventilation. Those patients are often very sick and very complicated. So I'm glad that you were able to secure his airway. I think we have now confirmation that the inflammatory disease is in the lungs, because you very rarely need to intubate somebody for any non-pulmonary problem. And the one exception is when a patient has devastating neurological diseases that impair their ability to protect their airway. So if you're rapidly trying to figure out what the cause of this problem is or where the inflammation is, you're told the patient is short of breath, necessitating intubation. And that that filter of necessitating intubation really ups the ante of the probability of pulmonary disease. It's very rare to need intubation from a pleural process, very rare to need intubation from a cardiac process, with the exception of cardiogenic pulmonary edema, and very rare to need intubation for a systemic process, with the exception of severe metabolic acidosis. So initially we were like, where is the problem? We thought it's in the lungs based on base rate. And now I think there's confirmation that this is in the lungs by virtue of the amount of ventilatory support this patient needs. And the practical piece of advice that I have for you in this patient is, if you have the resources, you know you need to get a chest imaging to understand the nature of this disease. But I think it's hard to argue that anything short of a CT chest with contrast will be sufficient for this patient. There's two reasons for that. The first is you really want to characterize the nature of the pulmonary involvement to the best degree possible. The second, and the value of the contrast here, is to recognize that many patients with structural lung disease, in particular COPD, have a higher rate than a general population of a pulmonary embolism. And so for those two reasons, I think getting complete clarity on the status of the lungs and the vessels in somebody who's intubated is very important. In the US, patients come into emergency rooms and their access to a CT scan is made harder when they're transferred to a unit, because the distance between the CT scanner and the unit that they are transferred to is often higher than the distance between the ER and the CT scanner. So from a practical perspective, especially for those of you hoping to match in the US from other countries, this may not apply to your practice pattern, but in the US, your chances of getting a CT scan safely are reduced once the patient's transferred to a floor. It's not impossible. It's certainly necessary if it's done, but This is the kind of patient who you say simply, I don't want to think too hard. They're in a critical respiratory state, and I need to know exactly what's going on in their lungs. And for me, a trip to the CT scanner with contrast really, really helps a lot, even if the chest X-ray provides a profoundly helpful answer. So say, for example, we learned that this patient has COPD and has a pneumothorax. You see that pneumothorax, you put in a chest tube. Are you done? I don't think so. In large part because the hypercarbia and the fever are not explained. So no matter what, I think a CT chest with contrast will be very important. So where are we now, big picture? I think we need to understand what's happening in his lungs, both currently and what we think is going on from the past. And at the same time, we need to make sure we don't overlook any extrapulmonary diseases. All right, Srinath, back to you.
Yeah, thank you. That was a really a very great explanation for that and intriguing. So for the labs and imaging for his hematology, his WBC count, there was mild leukocytosis with neutrophilic predominance, and the count was around 11,000 at the day of admission. His hemoglobin was 12.2. His platelets were around 220,000. And the ABG drawn at the time of admission was pH was 7.30. PaO2 around 58 millimeters of mercury, PaCO2 60 mmHg, and his bicarbs were around 30 milliequivalents per liter. CRP was also 15, and chest X-ray at the time of admission showed hyperinflated lungs with flattened diaphragm, and there was no pneumothorax or consolidation at that point of time. His chemistry, sodium was 138, potassium 4.2, chloride was 100, and blood urea BUN is 32, creat is 1.8, glucose 95. His calcium was 9.2, magnesium 1.9. His LFTs showed AST at the level of 85, ALT 72, and ALK-Phos 62, albumin 4.2. Troponins were 0.05, and the blood cultures which were collected on the day 1, on the day of later on the day 4th, they showed positive for gram-negative bacteria. And on the subsequent days when the patient was intubated, after that, when the chest CT was done, it showed characteristic panlobular emphysema with multiple bullae in both lungs. And in the chest CT, the pneumothorax was detected, which was treated with chest tube insertion at that point of time.
Absolutely excellent presentations. This is so awesome, and only matched by Sarah's incredible ability to keep up with your flowing presentations. That was really cool to see you catch up with that. I think there is so much helpful information here to help us understand what's going on. And there are so many of you here that I think it's probably a good idea to do 5 minutes of breakout rooms just for you all to chat and share your thoughts amongst a smaller group. So I'm making a few breakout rooms. I'd really encourage you to join and just chat amongst yourselves about what you think is going on. And then 3 or 4 minutes later, I'll just invite you all back here and I'll just share my thoughts. But I think it's a really good time to get to know people you haven't met and just get your voices heard, which I'm sure are profoundly helpful. If you can't join a breakout room for whatever reason, please feel free to hang out here. We'll just be back in a few minutes, okay? But if you can, please do. All right, I'd love to hear from somebody. I love to hear from somebody what their thoughts were. I saw Elena and Noah. You guys were in a room together by yourselves. Elena, do you want to just summarize what you guys chatted about? I can see your. I can. Yeah, go for it. What did you all talk about in your room?
I mean, Noah was just asking me questions.
Okay.
So I don't know. Yeah. I mean, we were like talking about basically what we were talking about before as well. I think our main concern is still like with the trans, like despite the transaminitis, is the lung.
Yeah.
And we were also talking about if there's like a chance that the gram-negative could be like a false positive, but this is more common with like gram-positive.
Yeah. Excellent.
bacteria. So we think it's yeah, it's true.
Yeah.
And I was saying that I know that, for example, in patients with cystic fibrosis, Pseudomonas is a very
Yeah.
serious bug that for those patients, they sometimes have like weeks and months of treatment to like just get rid of that
Right.
bug.
Yeah.
And yeah, so I mean, we have to like stabilize the patient. I mean, the patient has already been intubated, so
Yeah.
yeah, I mean, there's like a hepatopathy pattern, but we're less concerned about this, but to like maybe like put like the lung issue and the liver issue together, especially with the kind of like young age. We were
Yeah.
concerned about like CF,
Yeah.
and also like the alpha-1 antitrypsin deficiency.
Yeah. I love it. You seem so comfortable sharing your thoughts out loud in the space. It's really cool to see. Though I imagine internally you probably are. I remember that feeling. But yeah, sorry to pick on you, but I'm not really sorry because I think you did such a marvelous job there. And you'll see, and I'd love for you to like track your thoughts and what you just said, and how every single thing you said is going to come up in the conversation that we have together as a group. Everything, including the gram negatives, including the structural lung disease, including the liver stuff. We're all going to talk about that. Maybe I can ask Sarah to share the whiteboard because I forget what the exact pictures were. But yeah, I'll share my thoughts as they evolved in real time, which is the first thing that we got was the ABG. And I think there's this sense that an ABG tells you a lot about the current respiratory status of the patient, and that's true. But don't forget to use the bicarb as a sense of the chronicity of the disease. And so we knew that the O2 and the CO2 were not going to be pretty for this person, but the bicarbonate, serum bicarbonate is a marker of compensation over time. Your kidneys can't adjust the bicarb quickly, and so an elevated bicarb is likely in this context suggested of a chronically elevated CO2. And so if you put yourself in the reality of many instances where you don't know the patient that you've just intubated, you just met them, they're like huffing and puffing, you can't get a history, boom, intubate them. The bicarb tells you there's chronicity, and it helps you localize where in the lungs the problem is. Because in the vast majority of patients who have CO2 retention that is triggered secondary bicarbonate retention have an airway problem. So immediately you're like, okay, interesting. I think this person has an airway issue, and that would be further supported by you putting your stethoscope on their lungs and hearing wheezing. And that builds the case for an airways issue, which is a great thing to keep track of, because if your patient with an airways issue suddenly becomes hypoxemic, that should really prompt you to worry about the patient having a pneumothorax. In fact, the most common cause of non-traumatic pneumothorax occurs in patients with airway issues, namely COPD and the other cousins of COPD, including something that Elena mentioned, cystic fibrosis. So if you're like, oh, I'm worried this person has an airway issue, boom, they suddenly get worse. Pneumothorax has to be on your mind. And that's a complication that you see that this patient had, which I will note was not noted on the x-ray and then noted on the CT, which may have been a time difference. It may be that the pneumothorax developed after the x-ray was obtained, but as a reminder for you of just the higher performance characteristics of the CT in complex patient. So that entire theme that we just talked about is nothing more than just reinforcing the history that this person has a chronic airway issue. And the only thing that will elucidate that chronic airway issue with a high degree of certainty is the CT scan. Now, before we talk about the CT scan, well, what are our options for chronic airway issues? And we often immediately reflexively think of the common things, COPD and asthma, but let's take a minute to be systematic about it. The airway issues, if you're systematic, are best structured anatomically. Upper airway, middle airway, and then lower airway. The middle airways are much more common, but Mark presented a fascinating case of a patient who had recurrent episodes of dyspnea that had an upper airway problem. I won't spoil that case for you, but it was about two or three Thursdays ago. The lower airways problems really refers to the entity called bronchiolitis, which most of us are most familiar with in the context of acute bronchiolitis, which is usually a disease, a condition affecting kids, often from RSV. But in adults, chronic bronchitis can occur, or bronchiolitis can occur, excuse me. Middle airway diseases are either COPD, asthma, or bronchiectasis. And in this patient, the base rate is true. We see that this patient has extensive bullae everywhere, reinforcing the initial diagnosis that he got of COPD, which would be, of course, further supported by PFTs, which we probably don't have. Now, the question is there any other evidence for chronic lung disease before we talk about the most pathognomonic signature of the CT chest? And the answer is yes. And that is what Elena talked about, the gram-negative rod bacteremia. In most comers, gram-negative rod bacteremia comes from two different places, the GI tract or the GU tract. In the United States, GU causes are much more common than GI, but that's flipped in many parts of the world owing to higher rates of enteroinvasive organisms. However, structural lung disease, as Elena emphasized, in patients with bronchiectasis can get Pseudomonas, but any structural lung disease changes the biology and colonization of the lungs, initially favoring gram-positive organisms, but ultimately advanced disease favors gram-negative organisms, and you see that here. So if you see respiratory distress requiring intubation and gram-negative rod bacteremia, you should immediately think, what is the chronic lung disease this person has? Acute disease from gram-negative rods coming from the lungs can happen, but it's usually uncommon organisms, or it's in a hospitalized patient who's already been intubated in the hospital. So we're solving a problem of chronic lung disease here in the form of emphysema. And the question is, that Elena already brought up, is are there any prominent extrathoracic clues? And I have to be real with you, I think the answer is maybe not. Because the AST and ALT elevation is so mild, and the kidney injury, which are the two things that were abnormal, are so mild, it's really hard to know whether we should call them signal or noise. And in most patients who are critically ill in the ICU, if they don't have these numbers, you probably wouldn't believe the lab test. It's that common to get kidney and liver perturbances in patients in the ICU. But what's the most unusual is having a 52-year-old man having panlobular emphysema. In patients with COPD triggered by biofuel or smoking exposure, the emphysema tends to be asymmetric and tends to be upper lobe predominant as a result of the flow of smoke and dust upwards, preferentially affecting the upper lobes. The fact that this person has panlobular emphysema should make us wonder where they have secondary disease, and the fact that they're developing this disease in such a critical near terminal phase at the age of 52 is very alarming. So I will share with you a visual about secondary causes of emphysema. And here they are. You already talked about all of them. On brief glance, his AKI can make you wonder whether he has this. His family history can make you wonder whether he has this. And he definitely has a lot of exposures, which we heard about, which would be the exposures and the other category. The most common cause, however, is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is a lung liver syndrome, but the mode of presentation is determined by the specific genotypic mutations and the age of the patient. Extensive emphysematous changes is much more common in older adults, in contrast to liver disease, which is usually common in younger patients. And the difference has to do with the mechanism of disease. In alpha-1 antitrypsin disease causing liver disease, it's usually the result of toxic accumulation of unprocessed molecules that results in liver dysfunction. In contrast, the lung disease is as a result of insufficient neutrophil clearance, insufficient neutrophil balance over time. And so patients can accumulate their toxic molecules and result in liver disease at a much earlier stage. In adults, the phenotype is much more lung predominant. So in this patient, I think the actionable steps are to study the kidney function after hydration to ensure that's not a signal for vasculitis. But I think the key next diagnostic step to wonder is, what is this patient's alpha-1 antitrypsin level? There are some nuances with the level itself. It can be falsely elevated in acute phases like this patient might be. So we can talk about the nuances of interpretation if it's pertinent, but that's, I think, the next most important diagnostic step. That is not as important as treating the gram-negative rod bacteremia, the pneumothorax, and the respiratory failure this person has. All right, so tell us what you were thinking and what you all did next.
Yeah. So the next step after we got the CT test was we sent a genetic testing for the patient. And so yeah, as we were discussing about that, it came out that the patient had alpha-1 antitrypsin deficiency, and the genotype was ZZ genotype, and that basically confirmed the diagnosis for alpha-1 antitrypsin for us at that point of time.
Incredible. Thank you for that. Well, I would love to get your thoughts on that in a second. I'm just curious if you can tell us how the patient did. How was his hospital course?
Yeah. So initially, when the patient did present it to us, we also thought that this is a case of COPD exacerbation. So we started the patient on systemic steroids and prophylactic antibiotics, because the patient said that he had change in purulence, and that was an indication that we could start antibiotics in this particular hospitalization. And before that, we also drew the blood cultures for this patient. And for his day one, the chest X-ray was done. His ABG showed a case of respiratory acidosis with compensatory metabolic alkalosis, but there were no signs of pneumothorax, or in that particular day, on day one, there were no signs of pneumothorax. And on the subsequent days, we ordered the CRP levels, which were high. And later on, when the patient saturation was falling, we had to intubate the patient. And unfortunately, I think because of the high PEEP that the patient was getting, he got pneumothorax because of that. So because it was not, CT scan was not done before, so we didn't knew like the patient might be having bulle or something like that. So as soon as the patient was started on ventilation overnight, we saw that his saturation was again falling. So we had to do a CT, and that showed pneumothorax, and that's why chest tube was placed in that case. And when we got the report of the CT, because there was written panlobular emphysema, so the dots connected, because his father also died from some liver disease. So we again repeated the LFT, so they were elevated. And then we sent the patient for genetic testing, because he was not financially sound. So that's why we wanted to make sure that before sending the genetic testing, we are pretty sure that it could come out positive in that and help us find the cause. So in that case, the genetic testing came positive for alpha-1 antitrypsin. So later on, we for the management of this particular patient, we continued the same medical management, but we also tried to have the genetic counseling for this particular patient, so that his family does come to know like what exactly was the cause of his father's death, probably the same thing, and how this disease could affect in a long term for them.
That's so illuminating. Thank you so much. How was he able to be discharged from the hospital, or what was his course with the intubation?
Yeah, so later on, when we started also on the replacement therapy, we tried not as soon as we got the diagnosis, but we like informed after the genetic counseling we had arranged for that thing, and because cost was an issue, so it was done later on for that particular patient. But with the critical care management, the patient was discharged, and he had around a 10-day course of hospitalization for this thing, and later on, when he was stable, yeah, the patient was discharged on the bronchodilators and inhaled steroids. And also there was a genetic counseling follow-up for this particular patient.
Okay, absolutely outstanding. Do you happen to remember if you ever obtained a serum alpha-1 antitrypsin level, or did you skip that in this patient?
No, I think the report did came, but I wasn't sure like what the level was.
I see.
So yeah.
No problem. Yeah, no problem at all. You got a much better test than genetic testing. So I can understand why that didn't make it here. I think there's so much learning in this case, and I think the biggest thing that I would like to emphasize is just the importance of asking and wondering what the underlying vulnerability is in a patient with an acute respiratory process. And the reason that question fades for most of us in clinical practice is because we're so used to knowing the answer already. The patient is 92 and aspirates, or the patient is 65 and has really had really bad bronchiectasis. But young people don't get this sick from the usual stuff. And for me, the reason this case from the get-go should cause alarm bells beyond the fact that it's being presented so well in this context is the age of the patient. I can't emphasize that. And you can pick up clues as to the chronicity of this disease from a very savvy history, which Sridhar did, but also from the biomarkers of chronicity, which here were the compensatory metabolic alkalosis, the high serum bicarb, and the gram-negative rod bacteremia without overt GI or GU disease. Those tell you the patient has had a significant damage to their lungs. And then that becomes about recognizing what is the pattern of that recognition. Is it bronchiectasis? Is it ILD? Is it emphysema? And then you can quickly Google or ChatGPT your way the answer. So I really, really took that away. What was your biggest takeaway, Sridhar, from experiencing this case?
Yeah, I think the CT finding was a biggest takeaway, because I think COPD exacerbation is like quite common in India as well. But I think this was the first case because I don't think like alpha-1 antitrypsin is as common as in US. And even my attending told me like it would be his fifth or sixth case that he's seeing. And so that is why he always thinks of this particular diagnosis very rarely. So that is why it was initially a usual case of COPD exacerbation for us, but the way it turned out in the last was kind of amazing. And that's why I think it also emphasizes that we should always have these rare conditions in mind, because we never know when we are going to see them. Yeah.
That's a fantastic takeaway. I really think that you've presented this story and honored this patient and his story so well today. I think that if we were working together in real life in the future, I would have all the confidence to work with you and learn with you with how effortlessly you presented this patient. And I hope that you have inspired many others to take that leap and also present their case, because ultimately this is the outcome. You get to showcase your incredible medical skills, and you get all the rest of us to benefit from your incredible knowledge. So we really, really appreciate your time. And with that, I'll pass the mic to Aisha to tell us the teaching points. Almost done. Yeah. Go for it, Aisha.
Thank you so much for the case, Sridhar. And Rabih, I always get amazed how beautifully you walk us through every single case and how well you educate us. Okay, so for teaching points today, we had a 52-year-old male patient from India who presented to the ED with respiratory distress for the past 2 days, worsening productive cough, fatigue, and fever. So right from the start, we were thinking about the presence of inflammation, and we were leaning towards the lungs, which is most common. So we think about three things: presence of inflammation, where is the inflammation? Two thing, how long has what is the time course? That will help us figure out what type of etiology it might be. So acutely, which is in a few days, we would be thinking about community-acquired pneumonia. If it's longer duration, we would be thinking about another etiology. And the third thing we need to consider is why is the patient leaning towards pneumonia? It would be in a young patient specifically here with the age. They might have age-related immunosuppression, or they might be an underlying structural disease. So some of the common causes of COPD exacerbation we know, but the ones that we need to take into consideration is secondhand smoking, or pneumoconiosis, or other environmental exposures such as biofuel. And we need to think about more towards the lungs, because it's the most common cause of inflammation with this kind of presentation. And when we got the vitals and we saw that the patient was tachypnic, we need to figure out if it's because of hypoxia, or is the patient acidotic. And with the pulmonary exam, we kind of confirmed that it
shows us that there's impaired oxygenation and impaired ventilation. And because this patient was receiving ventilatory support, they had shortness of breath and they required intubation. That most likely increases the probability of a pulmonary disease, because this much severity requiring intubation would be rare with a pleural process or a cardiac process, with the exception of cardiogenic edema, or even more rare with a systemic disease, with the exception of severe metabolic acidosis. So at this point, we were thinking a CT chest with a contrast would be very essential. Even though a chest X-ray is adequate, it would not explain the hypercarbia. And here it would basically help us to characterize the nature of the pulmonary involvement, and it would show us, and we would do a CT scan with contrast because of the severity of the patient. And once we received the ABG, the bicarb, essentially the bicarb compensates over time from the kidney. And in this patient, it was increased. So that kind of told us that it could be chronically elevated CO2. And we would need to do a CT scan, which can confirm the chronicity issue in this patient. And when we're thinking about airway disease issues, we need to characterize them into upper, middle, and lower. So upper and middle, the most common would be COPD, asthma, and bronchiectasis. And lower, we would be thinking about bronchiolitis, for example, RSV in kids, and chronic bronchiolitis in adults. And then we came to find out there was gram-negative bacteremia and intubation. So in that case, we're leaning more towards a chronic disease and less likely moving away from an acute disease. And some of the causes for COPD triggered by biofuel and smoking, which could possibly lead to emphysema. So we have two types of emphysema, centrilobular and panlobular. Centrilobular, which is the upper lobe dominated, it is essentially due to the smoke rising upwards in a lung lobe and causing centrilobular emphysema. Panlobular would be due to secondary diseases. So this could be due to vasculitis, which can possibly explain and support the AKI in our patient, or it could also be due to genetic causes such as alpha antitrypsin deficiency, which was the final diagnosis in our patient. And thank you for listening.
Thank you for amazing teaching points. I was apparently hypothetically jet lagged, but clearly that's not in the way of constructing such an organized thought through this case. Thank you, Aisha. That was awesome. Thank you to all of you for joining us today, and a special thanks for Siddharth for an absolutely wonderful case. We really hope to see all of you next time.
Yeah, thank you so much for giving me this opportunity. And I think I even had more learning than we had during handling this case. So thank you so much for being such a great audience, and I look forward for many cases ahead in future and connecting with you.
Absolutely, and best of luck in the match process. We hope you share some of your journey with us when you join in the future. Bye, y'all.
Yeah, thank you. Bye-bye.